Hello everyone, welcome back. Today I'll be covering multiple hereditary exostosis, a part 3 video. This video is covering all the complications associated with MHE. Start off with osseous deformities, especially Erlenmeyer-Flass deformities, impingement, bursar formation, displacement, compression, stenosis and occlusion, vascular complications, and lastly, fractures. Regarding osseous deformities, commonest complications that affect the growth and cause local side effects such as misalignment and bone inclination. These abnormalities are most exclusively encountered in patients with multiple hereditary exostosis. Radiograph will show Erlenmeyer-Flass deformity. This term derived from a type of laboratory flask which has a conical base and a cylindrical narrow neck joined by uncurved edge. This figure illustrates the Erlenmeyer-Flass, also known as conical flask or a tritration flask. It has a flat bottom, a conical body, and a cylindrical neck. More about Erlenmeyer-Flass deformity. For osseous deformity, the radiograph will reveal metaphyseal widening with an Erlenmeyer-Flass deformity in the distal femur. That's the commonest side. This deformity can be found at the proximal end of the humerus and tibia and distal end of ulna and radius. The deformity results from defective bone modeling or undermodeling arising in the metaphyses adjacent to the growth plate and with time can extend into the diaphysis. This X-ray shows the Erlenmeyer-Flass deformity. You can see it has a flat bottom, the conical body, and the cylindrical neck. Could you appreciate it? More regarding osseous deformities. These deformities are often located in the forearm or wrist. Around 30 to 60% of multiple hereditary exostosis. They include disproportionate ulnar shortening, ulnar deviation of the wrist, deformed radial articular surface with distal radio-ulnar joint disruption or dislocation of the radial head. Other parts may be affected: costa valga, journal valgum, ankle valgus by talocrural disjunction, leg length discrepancy, and short stature. These deformities result in asymmetrical growth, functional impairment, and unsightly deformities. Again, this X-ray of the right forearm shows the right ulnar shortening and dysplasia due to the complication of multiple hereditary exostosis. When exostosis develop in contact with another bone surface, such as in the interosseous space between the tibia and the fibula, deformities of the adjacent bone may be observed, resulting in erosion and or scalloping of the bone surface. Surgery aim is to prevent or limit and correct the deformities. Again, this X-ray shows the pedunculated tibial exostosis causing fibular deformity, and this compression results in erosion or scalloping of the bone surface as circled, and the arrow showed the erosion or scalloping again. Next, regarding impingement. On joints, exostosis may cause impingement and repeated friction during movement. Mechanical effects of impingement are limited range of movement, friction, and trigger tendons or ligaments, and early osteoarthritis. Usually in scapula and usually at the anterior surface of the scapula. Two consequences may follow. Number 1, the impingement upon the posterior thoracic wall with or without bursitis, resulting in a snapping scapula with typical crackling when the scapulothoracic move. Number 2, posteriorly displaced scapula with limited range of movement. This causes wing scapula. Positional disorders mainly concern the young patients and are usually painless. Again, as this X-ray of shoulder region shows exostosis that is noted at the right scapular region. Next, regarding bursal formation. Bursal formation overlying exostosis around 1.5%. The main area affected are scapulothoracic joint, hip and shoulder. Clinically, a palpable lump seen in osteochondroma that grow rapidly is often painful. This bursa may stimulate malignant chondrosarcoma transformation. The bursa may become inflamed, infected, or even hemorrhagic and contain small cartilage fragments. Regarding displacement, compression, stenosis, and occlusion complication. Displacement is frequent but asymptomatic. It frequently correlates with the size. In patients with hereditary multiple exostosis, stenosis is observed if osteochondromas are large and more particularly in the arteries in the leg. There are no hemodynamic consequences in young patients due to the high arterial blood supply. Occlusion is exceptional. This CT image shows sessile exostosis that projects into the anterior tibiofibular interval and compress the left tibiofibular trunk, as shown by the arrow. And it is a common sessile exostosis. Regarding vascular complication, it is rare. Arterial complication represent 90% of vascular complication. 4 types can be observed. These include vessel displacement, stenosis or thrombosis, occlusion, and pseudoaneurysm formation. The venous complication include thrombosis and compression. Lastly, regarding fractures. Fractures are unusual complications of exostosis that result from trauma. They occur through the neck of a pedunculated exostosis because the pedicle is the weakest part. Radiographs often are adequate to show fractures. CT and MRI are useful in case of doubtful diagnosis. Cases of spontaneous osteochondroma, regression, and even resolution have been reported. This figure of a CT scan shows there's a fracture occurring at the base of the pedunculated exostosis. Yay! We have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.